back to that work. It's my pleasure, of course, to be able to welcome a special guest to Canada's Drug Futures Forum. Before I introduce the Minister to you, however, let me take a moment to introduce you to the Minister. Joining us today from across the country, from Europe and the Americas, more than 150 individuals, among them drug users, policymakers, international experts, lawyers, judges, law enforcement, health providers, administrators, academics, advocates. This is quite a consortium of individuals who care passionately about advancing drug policy in Canada. We have been working over the course of what will soon be 2 days in order to hear from more than 20 speakers. We've been addressing in our work this morning a range of issues, including drug supply, border control, collaboration between first responders, changes to justice policy and practice, drug regulation and models for decriminalization, as well as the racialized harms of drug policy and equity in harm reduction. We're very excited about the work we're doing, and later this afternoon we're going to report back from all of those groups. That'll be the basis for a report which we'll be very excited to share with you the results of our discussions in the weeks to come. So, having introduced all of you lot, let me now introduce the Minister. She is, of course, the Honorable Dr. Jane Philpott, the MP for Markham-Stouffville. She was elected in 2015 and joined Cabinet as a rookie MP with a very large portfolio as Minister of Health. Prior to politics, she was a family physician and continues her family practice. She was as well the chair of the Department of Family Medicine at Markham-Stouffville Hospital. She has worked passionately for medical education in Africa on the subject of HIV/AIDS and refugee advocacy, and importantly, the social determinants of health. We're delighted to have you join us at Canada's Drug Futures Forum. Minister. We do have translation, so be mindful of pace.
Okay. Good afternoon, everyone. It is a great pleasure to be here. Congratulations on bringing this fantastic group of people together. I'm very happy to spend some time with you this afternoon and share some thoughts that will hopefully stimulate further discussion as you go from here. I want to acknowledge that we are on the land, the unceded territory of the Algonquin, and very pleased to be able to be welcomed here to this land and to acknowledge the people who have gone before us in this place. It was mentioned that I have a background in medicine, and so to set the context for this talk this afternoon, I wanted to talk to you about a patient named Cynthia. That's not her real name, but she's a real person. Cynthia is a former patient of mine who suffered from opioid use disorder. She became dependent on opioids due to a series of tragedies in her life that included the death of 2 of her children in a car accident when they were very young. She remained dependent on opioids because of a complex array of circumstances that included chronic unemployment, homelessness, repetitive sexual abuse, and a lack of social supports that might have set her on an alternate path. I did, in fact, leave my clinical practice at the time of the 2015 federal election and have not returned to clinical practice, but I often think about individual patients. And in the case of Cynthia, I think of her not infrequently, and I wonder if she's still alive. I wonder if she has managed to avoid buying a bad batch of narcotics on the streets of York Region. I worry about whether she has become a statistic, one of the thousands of Canadians who will die this year because of a drug overdose. It's safe to say that Cynthia tested the patience of my staff at the clinic. Her life was erratic, her behavior was unpredictable, and her compliance with treatment was almost impossible. But I liked her very much. She was smart, charming, curious, and always kind. And of course, even if she possessed none of those qualities, she still deserved good care. My determination to see the end of the overdose crisis that we're facing in Canada is quite simply because people like Cynthia deserve to live and be well. Cynthia, and be well. I know there are a whole range of topics that you are discussing over this two-day period at this conference on Canadian drug policy, but I want to focus my remarks primarily on the matter of opioids and the rising mortality rates from overdose. I have been outspoken about the fact that this overdose crisis demands a whole-of-society response, and so how very appropriate that you have reasonably good whole-of-society representation here. Our response to this means calling out stigma and discrimination associated with drug use. It means having a society where children receive tender care from before the time they're born, where adults aren't so lonely and isolated. It means identifying smart policy alternatives and implementing them broadly. A national opioid crisis demands our collective courage, creativity, and resources. In 2017, every one of us has to work together to apply solutions and to save lives. Votre rencontre à Ottawa cette semaine est une partie essentielle de l'identification de solutions. J'espère que vous travaillez ensemble pour exposer des options, pour pousser à la collaboration et pour inspirer des actions qui vont renverser le cours de la plus grande crise de surdose dans l'histoire canadienne. Il y a plusieurs raisons pour lesquelles nous devons moderniser notre approche à l'égard de la politique sur les drogues au pays. Je n'ai pas besoin de dire à cet auditoire qu'au moins une province au pays a connu une augmentation de 80% des morts dues aux surdoses de 2015 jusqu'à 2016. C'est choquant et cette tendance doit être renversée. Indeed, one of the most deeply concerning aspects of this crisis, which frustrates all of us, is the appalling dearth of data and the glacial pace at which we're getting updated information. The crisis of overdose deaths is one of the biggest public health challenges that our country is facing, and we simply don't have the data we need. We don't know how many people in Canada are currently affected by opioid use disorder. We don't know yet how many people in Canada died last year as a result of overdose. There are challenges associated with getting that meaningful data related to opioid use, but it is not an excuse. We need all stakeholders to come together to provide a complete picture of the experience of opioid users. This needs to form the basis of learning by policymakers like myself, by managers, clinicians, and many others to do better and to apply what's working. No doubt you've already discussed the matter of data gaps among many other pressing priorities for our work ahead. But of course, our top priority, I would suggest, is to stop the steady stream of death. I want you to know that I have been fixated on this crisis from the start of my mandate as Federal Health Minister. I've tried to be very clear about the principles that inform our approach to drug policy. I have repeatedly stated that the approach must be comprehensive, collaborative, compassionate, and evidence-based. And I'd like to take a few moments to touch on each of those four principles. First, the response must be comprehensive. We must not fool ourselves into thinking that there are simple solutions or that any single policy decision is going to change the course of this crisis. A comprehensive response requires the classic four pillars of prevention, treatment, law enforcement, and if you haven't already realized it, under our government, we have reinstated the pillar of harm reduction. At the federal level, a comprehensive response has included a number of steps so far. One of the first things I did as Federal Health Minister was to change the status of naloxone to be available without a prescription. We have made naloxone more widely available in multiple formats. We have granted so far under our government exemptions for 5 supervised consumption sites. We have tabled legislation to streamline the application process for similar sites. And on that point, I want to emphasize the importance of Bill C-37, which is currently before the Senate. I believe some of you who are here today are in contact with the Senate or appearing before them, and I want to encourage you to please do all you can to push for swift passage of that bill through the Senate. We have enabled, via the Special Access Program, a variety of treatment options, including pharmaceutical-grade heroin, and overturned the ban that was previously associated with that. We have deployed epidemiologists, we've worked with coroners and medical examiners and public health leaders to improve information gathering and work to improve that evidence base. We hosted a summit with 42 organizations who have committed to concrete action to address this crisis. We have committed new funding to research for opioid use disorder and other treatment options. And we've invested new money into the Canadian Drugs and Substances Strategy. And on this matter, I want to clarify what you heard this morning. That in fact there was more than $100 million new dollars in budget 2017 for the Canadian Drugs and Substances Strategy. We changed the name from the National Anti-Drug Strategy to the Canadian Drugs and Substances Strategy. The A-based funding in that continues, and it was previously $570 million over 5 years. Budget 2017 gave an almost 20% increase to that strategy, so it now sits at close to $700 million over 5 years for the Canadian Drugs and Substances Strategy. Only a portion of the response of what our government is doing to respond to this. We provided $16 million in direct emergency funding to Alberta and British Columbia. And I hope I don't need to tell people in this room that it takes more than direct funding for health to be able to respond to a crisis like this. $11 billion in a national housing strategy. Housing is one of the important determinants of the health of all Canadians, including Canadians who use drugs. We invested $5 billion to the provinces and territories for increased access to mental health care, which has clear and obvious links to drug use and problematic substance use. So I want you to know that together with a range of other partners, I believe that each of those decisions is moving us in a better direction. I want you to know as well that I'm listening to you. I'm listening to those of you who are on the front lines and hearing many of you say that it's not enough and that it's not fast enough. And I want you to know that every time you tweet at me and tell me about the fact that you've saved lives because you've given a certain number of people naloxone, or you tell me about the lineups outside the morgues in Western Canada, I want you to know that I hear that and it cuts me to the core, and I will work every day to turn that around. So please do not take the fact that I cannot fix this overnight, just like none of you alone can fix this overnight, does not mean we are not working every single day to solve this. Which brings me to the second principle, and that is collaboration. I want you to think back and tell me when you think that you've had a federal government or a federal health minister who has been as determined to work alongside you on progressive drug policy, and I believe that it's been at least a decade since you've been in that circumstance. So I want you to know that we have to work together. I just met with a group of people who represent people who use drugs, and I made the point to them, and I hope they heard it in the spirit in which it was intended, is that we can't argue with one another. We are working towards very similar goals, and we have to help one another. We do not have time to waste in arguing and in making life difficult for one another, because we have work to get done. So the more that we can collaborate together, the better. I want us to work together in a spirit of solidarity, in a spirit of mutual support. We will not turn this around by fighting one another. We have a common enemy, and it is not in this room, okay? The enemy is a whole lot of historic and policy forces and health realities and legal realities in this country that need to be changed over time, and we need to collectively work together to see those realities change. I want you to know that I am determined to stop the unrelenting stream of death. I can't do this alone, and neither can any of you. We have to work at it together. That means working with our partners. It means working, again, respectfully with partners in provincial and municipal governments, with health professionals, with regulators, with educators, with first responders, with civil society organizations, and many, many more. A crisis of this magnitude requires a whole of society response. I want to note, for example, the efforts of groups like the law enforcement community, who I hope are represented in your gathering here today, who are working hard hand in hand with those who until very recently have been seen as perhaps enemies, antagonists, or adversaries. And in case it's not abundantly clear, collaboration absolutely means including and listening regularly to the voices of people who use drugs. I know that this meeting includes many people who have lived experience, and I absolutely commend you for that. I hope that it is evident to the people that are most affected by the overdose crisis that policymakers like me are listening. We depend on hearing your views and your informed perspective. The group of people I met just before I came downstairs today, I said I will always be open to hearing your suggestions, your recommendations. I'm absolutely happy to hear your criticisms along the way, but let's do this in a spirit of finding the ways, the levers that each one of us has, and making steps to use those together. So that brings me to the third principle, that of compassion. Nous avons beaucoup de travail à faire en matière de compassion. Je n'ai pas besoin de dire à cet auditoire que les gens qui ont des dépendances aux substances font souvent l'objet de stigmatisation et de discrimination. Je ne suis pas sûre qu'il y ait un autre problème de santé dont les gens atteints sont plus susceptibles d'être blâmés, maltraités et se voir refuser des soins que le problème de la dépendance aux substances. Ceci est bien sûr non seulement d'aucune aide, mais cruel. I'll repeat that again in English for those of you who, like me, understand most French, but not 100% of it. Because I think it's an important point. I don't think, I actually had my daughter is in medical school, huge advocate for responding in a progressive way to drug issues in this country, and I said to her, do you think there's any other problem, health problem that people face for which they are more liable to be blamed, to be judged, to be kept away from having access to excellent care than the problem of problematic substance use? So we actually entered into a really interesting discussion about things like obesity and other types of challenges that Canadians face, but I'll leave that with you to kind of think of what that list is. But clearly it's not helpful that the amount of discrimination and stigmatization exists in the area of problematic substance use. Now, I want to make sure that you also understand that I understand that not all overdose deaths that we are facing in this country are related to people who have substance dependence. We need to be clear about that. We need to never simplify this problem and think that there's only one problem that we're facing. There's a complex range of issues that come together. The problem of opioid overdose and death among people who occasionally use drugs is a very serious matter and probably a growing matter. It has its own set of challenges that ought to be addressed, but that's not the subject of my comments just now. I think it's fair to say, though, that society reserves particular discrimination and judgment toward people not who use drugs occasionally, although there's judgment in that area as well, but particular discrimination against people who have become dependent on opioids or other drugs, and our response to people with addiction is especially in need of a lens of compassion. Beaucoup de Canadiens trouvent qu'il est facile de juger et difficile de compatir avec ce qui amène les gens à la dépendance aux drogues. Alors que tous les membres de la société ont l'obligation de traiter les gens avec des problèmes de dépendance aux substances avec compassion, dignité et respect. Il faut dire que les professionnels de santé ont une obligation claire à cet égard et qu'il y a certainement place de l'amélioration. Like any other health problem, the path to healing comes from listening to people's stories. Dr. Gabor Mate, who is probably a friend of some of you in the room, I have not yet had the privilege of meeting Dr. Mate, but it's on my to-do list. He has eloquently described and documented the stories of people that he cared for, particularly those in Vancouver's downtown east side. And when he was a physician at the Portland Hotel Society, he wrote about his patients and talked about how they had experienced pain upon pain, rape, beatings, humiliation, rejection, abandonment, and relentless character assassination. Mate has spent his career sharing the message that hurt is at the center of all addictive behavior. That hurt takes many forms, as you well know: emptiness, fear, exclusion, dislocation, and powerlessness. So when we say that our drug policy has to be compassionate, it involves acknowledging that unresolved pain rests at the core of problematic substance use. This has many implications. It means that appropriate treatment must include emotional care, counseling, and social supports. It also means that there's a great deal of work to be done in the area of prevention, to build a society where fewer people face abandonment and isolation, and where emotional trauma is recognized and treated as an important risk factor for further suffering. And so the final principle that I want to emphasize is that our drug policy must be evidence-based. Quite simply, we need to take a look at what works and what doesn't work, and then we need to do what works. So, given that frame, we have to be honest with ourselves. What we're doing right now is not working particularly well. In every region of Canada where we have data, the number of overdose deaths continues to rise steadily, essentially month by month. This is in spite of an enormous effort on the part of people like you, volunteers, civil society organizations, first responders, health professionals, legal professionals, and many others. This is in spite of more access to supervised consumption sites, new overdose prevention sites, wider access to naloxone, increased public awareness about the risks of high-potency opioids, particularly fentanyl, in the illicit drug market. So what evidence-based approaches can we look to that could help us? Many of you are familiar with the Salome and Naomi trials, the first clinical trials of heroin-assisted therapy in North America that were done in a Canadian context. And we owe a debt of gratitude to researchers and healthcare professionals who did this work. Any people, Naomi or Salome, people in the room that worked on those? They're not one or two that, okay, there's a few, yay. We owe a debt of gratitude to those of you who did this work, and it must be noted that it was done in the context of a fair amount of suspicion and hostility from government officials, including perhaps the politicians of the day. But as a result of this work, we know that heroin-assisted therapy can be a very useful tool for some individuals with problematic substance use where other treatment options have failed. We know from other research in this area that for some individuals, physician-supervised heroin injections are the only alternative to the use of street heroin. And it's clear that this can help not only those individuals by reducing bloodborne infections, for example, but the general population as well through things like lower rates of drug-related crime and lower healthcare costs, but moreover, it keeps people alive. It's important that we look to these strategies in the context of that comprehensive drug policy that I referred to earlier. What we can learn from other countries like Switzerland, for example, is that they have turned around rates of morbidity and mortality associated with injection drug use. We need to look to how that has happened through a process of open communication, research evidence, and building consensus among society and decision makers. As I said before, there is no single policy change that is going to turn the tide on this crisis in isolation from other measures. And of course, decisions about the practice of medicine rest with health professionals. Nonetheless, we must continue to look at the evidence that is before us, and no doubt you've been doing so at your meetings in the last 2 days. Mais nous avons l'obligation de prendre en considération ce que l'histoire et la science nous enseignent. Les gens qui ont une utilisation problématique des substances, comme ceux qui souffrent de tout problème de santé, devraient avoir accès à d'excellents soins de santé. Ceci devrait inclure l'accès aux soins de santé mentale et au soutien social. L'éventail complet d'options de traitement devrait inclure toute forme de traitement au moyen de médicaments. Ceci veut dire que les traitements de substitution aux opioïdes et, le cas échéant, des injections supervisées d'héroïne et de qualité pharmaceutique devraient être parmi les traitements offerts. Of course, I'm well aware that the delivery of health care is largely a provincial jurisdiction, but I believe that it's important to signal the views of the federal health minister. A paradigm shift in drug policy takes time, but it will take a lot longer if we don't talk about it openly and discuss opportunities to improve our approach if it could save lives and have multiple social benefits. As you may know, there are federal measures that must be undertaken to streamline access to all treatments. We have taken some already, including, as I mentioned earlier, overturning the ban on the Special Access Program for prescription heroin. We are considering other regulatory amendments that will further facilitate access to a range of treatments for opioid use disorder. The topic of drug policy remains politically and emotionally charged and open to controversy, but that must not deter us from an ambitious approach to finding and implementing solutions. So let's go back to the beginning of the talk and think about someone like Cynthia. How could I have provided better care for her? How could we avoid the incredibly high costs to our healthcare system in caring for someone like Cynthia, including high-priced medications for blood-borne infections and hospitalizations for a range of conditions from overdose to endocarditis to osteomyelitis? How can we help Cynthia and thousands like her to adapt from the perpetual chaos, violence, and pain of her life into a life that is predictable, peaceful, and productive? I believe it will take an approach to drug policy that includes the principles that I've described. The response must be comprehensive. It will require our ongoing work to collaborate well together. It demands a whole-of-society response and a lens of compassion, and we must be committed to an evidence-informed approach, even when the evidence points us in the direction of measures that seem challenging to implement. I want to thank every one of you for your commitment to this urgent matter. I look forward to working alongside you to save lives as we move ever closer to our collective goal of health for all. And in that spirit, please be creative, be bold, and be kind. Thank you.
Minister. Hands are already shooting up, and it's true, we are going to take 4 questions from the audience, and my colleague Joanna has the microphone. She's right over here. While she's making her way up to the top there for those first 2 questions, Minister, you talked about the need for a paradigm shift in drug policy, and you emphasized the importance of collaboration. I'm wondering if you can say more about specifically the ways in which people in this room can continue to apply positive pressure on this government to advance these important issues?
Okay, so I think it's essentially is that spirit of collaborating, of recognizing that we have an opportunity here. I hope you see this period of time as an opportunity. I think it's fair to say that the previous federal government was not particularly had views that may have differed from people in the room. So this is an opportunity. I am so deeply determined to get this right, to move us at the best pace possible toward the kind of solutions that I know many of you are seeking. That requires a really respectful relationship together. And as I said, I will be the first to admit that we will not get everything right, that there will always be room for criticism. That is the role of many of you in the room, but there's a way to criticize in a constructive way that doesn't sidetrack me. I know how easy it is to get sidetracked by all sorts of challenges that we face because of criticism. So let's find ways that you can channel in your ideas to me, and I've tried to make it known that my political office, as well as the folks in Health Canada, are open as the best view into me. So find a way that you can tell me what you think we need to do better without exploding it in the media, because that just actually takes my time away from getting the things done that I need to get done if I have to deal with those kinds of issues. I recognize that the role of advocates and activists is often to use media as your voice, as a way to get ideas out there, and I'm not trying to suggest that that shouldn't continue to be done, but let's do it in a way that we can help one another. The goal here is to save people's lives, to save people from suffering, to allow all Canadians to be able to enjoy a healthy and meaningful life, and the time for political battles in the media, I think we need to somewhat subside.
Okay, fair enough, and we certainly hope that the work we're doing at this forum can be part of that constructive engagement with your office. There will be a media availability for journalists following this session. Those members of the forum who are going to ask a question, I'll just ask you to introduce yourself and be as concise as possible in making your question.
Of course, thank you. Hello, Dr. Philpott, and thank you for addressing us today. My name is Jennifer Breakspear. I'm the Executive Director of PHS Community Services Society, also known as Portland Hotel Society in Vancouver. I want to thank you and the Prime Minister for visiting us over the last few months, touring the downtown east side, meeting with whom I like to call our first responders, the staff within our supportive housing operations within the downtown east side, the staff within Insight, and our overdose prevention sites. I want to ask, and I hear you about, you want to do things right. I tend to think of myself as a little bit of an overachiever, and so I know the urge to try to do things right, and sometimes feeling I need to take the time to get it right. I'm learning, particularly with my amazing colleagues at PHS, that we need to do it right, but we also need to do it fast. And sometimes that means we make some stumbles along the way in getting it right, but we get into action really quickly. So I want to share that from an overachiever about trying to get it right, but I also want to share in regards to when you are funding, which is, as the government, your main way of being able to respond to these crises, when you are funding in response to the overdose crisis, I would ask that when you fund, and I know your channel is through the province, if you can be giving direction to consult with the municipalities. It is the municipalities, and we've got colleagues here from Vancouver in the front row, who work most closely with us on the streets, right there at Main and Hastings, at Ground Zero. Our city staffers are the ones that know about the programs we offer, know about the good that they're doing, and know how urgently we need the funds. And I'm afraid that when the funds go to the provinces without such a direction, they don't make it to where we need it the most. So I would ask that, please, if such direction could go.
Thank you. I'll respond briefly. First of all, to say thank you very much for your all the things that you're doing and for being an overachiever and not being afraid to work hard and auto-correct along the way. You look like you wanted to say one more thing.
I do. I want to speak to, you cited Dr. Gabor Mate. He's on our board of directors at PHS. We were just in conversation with our board, and I know he'd be happy to meet with you. We could connect you later if you'd like.
Thank you. I have my team trying to plan that as well, so one way or the other, I'll get to meet him. So the other things I just wanted to touch on that you said, absolutely municipalities, and I probably didn't stress that enough in my remarks, municipalities have an absolutely essential role. I've been working with the Federation of Canadian Municipalities on this, and they've been very active, and obviously the municipal governments in many of our big cities are very much pressed with this, and you're right that we do need to find ways to continue to let them know where the resource supports are on that. Let's also make sure, folks, that when we're thinking, though, about the resource issue, that doesn't become an excuse for not getting things done, because I listed you the whole bunch of ways where I think that we have made investments which will make a difference on this, but sometimes doing things right is actually more cost effective than doing it wrong. That's probably should be self-evident, but much of the kinds of things that I've been talking about will actually, and that you are talking about here in these couple of days, will save governments money, right? So we know the tremendous cost to society. I don't need to outline it to all of you here by ill-informed drug policy. So we need to make sure that it's not always going to be about money, and that should never be used as an excuse.
All right, we've got time for just a few more questions. I see one here, and then we'll come down here and we'll conclude with Richard. If we can be as brief as possible.
Hi, Donna May from MUMSDO, the Family Voice in Drug Policy. Again, I'm going to testify on behalf of my experience with Minister Philpott and the always open door to suggestions and conversation around what affects family most after the death of a loved one. My question to you, Minister Philpott, is that today we were sitting in a strategy meeting and a point came out, and it made perfect sense to me, but who am I? You probably have a better understanding of whether it's possible or it's not possible and the barriers to implement it. My concern today is the number of phone calls that I get on now a daily basis of mothers and fathers who have lost a child. So the bereavement is growing. It's been personal with me, 3 overdose deaths in 3 weeks, and it's debilitating. It's causing me not to be able to do the work that I'm committed to doing. The suggestion that came up was that we have an opportunity to replace the drugs that substance users are using by supplying them an unadulterated drug in exchange for what they're about to use. Is that a consideration? Is it a possibility? And what are the barriers that might impede it?
Thank you. Nice to see you again, Donna. It's been a pleasure to work with you, and thank you for your work to help others who have shared in the same kind of grief that you've experienced. You know, there are already all kinds of opportunities that are out there that are not being accessed and being used for people who clearly have, for a whole variety of reasons, become dependent on the use of a particular substance. In this case, we're talking a lot about opioids, but there are other substance dependencies as well. We need to work with our colleagues who make a lot of the decisions in terms of the healthcare options that are available, and that includes health professionals as well as regional health authorities in provinces, et cetera, to make sure that when people have been identified with that health problem, that they have access to a range of treatments that are already available. I know there is more work to do in terms of a whole range of medication-assisted therapy and making it more accessible, but for instance, opioid substitution therapy, including in particular buprenorphine, is not widely available. Many healthcare providers are not yet comfortable in using it, and that whole range of medication-assisted therapy, including things like Dilaudid, for example, are currently available and not being used to the extent that they could be. So part of this is just a big education, and some of that is going to be done by some of the groups that we brought together in November to make sure that there's advanced medical education on these issues.
All right. I'm sorry, Don, I'm going to move on in the interest of time. We have a question here and then a last one from Richard.
Hello, I'm Nazli Maksudi from the International Center for Science and Drug Policy. Thank you so much for your remarks. It's great to see you again. So I just wanted to pick up on some of the comments you made around stigma and a public health approach. I really appreciate the comments around the need to address stigma in order to actually make sure that some of the problems around treatment and accessibility can be more meaningfully addressed. My question is around how meaningful destigmatization is possible in the context of a criminalization. I really see criminalization as systemic stigmatization, institutionalized stigmatization, and quite far from a compassionate and kind approach towards people who use drugs. So just hope that you can speak towards the link between criminalization and destigmatization if you see that as possible within that context. Thank you.
I think it's a fantastic question. Fantastic question. I think, it's not as much in my sphere, but obviously I work along other colleagues in both justice and public safety that have a role to play in that. You all hopefully all know that you have an amazing federal minister of justice who is very open to the kinds of, to reviewing our approach to drug policy amongst a number of other policies, and some of you I know have had a chance to work with her on that. I do think that there's basically all I can say is you're absolutely right. That's part of the challenge is that whole of society response and changing the views of society around opioid use and other substance use being a health issue and identifying when it becomes problematic, and that's going to take a whole lot of work on the part of a lot of people. One of the things I think we can do better at is showing really good models and scaling up the models that are there, because I think there are good models across the country. We were just talking earlier today about models for when people leave the criminal justice system and want to reintegrate into society, how we can make that a successful pathway, and I know that there are programs that do that well, and if we can support those programs, build the evidence base that they work, and then there'll be more opportunities to use those. So that's not a very succinct answer, but thank you for what you're doing on it.
Thank you. Last question, Richard.
Thank you, Minister Philpott. Good to see you again. I actually had 3 questions I was going to ask you. 2 of them have just been asked, so I'll say what they said. Those are important questions, and I think it would be important on the decriminalization front to perhaps work with policy experts and community organizations, including people who use drugs, to articulate from a health perspective why we need to move forward to decriminalization and not just stop at cannabis. But I'm going to ask you the third of my questions, and you won't be entirely surprised to hear it, and that is about how we scale up harm reduction that is comprehensive, including in prisons. I know that you are a strong supporter of having comprehensive harm reduction programs in prisons, including access to sterile injection equipment. I certainly have the sense that a number of your colleagues around the cabinet table are supportive of that because they've expressed that to us. So how do we make this happen? How do we make this happen? And what can we look for from you as health minister to help us advocate for an evidence-based response to problematic drug use in prison?
Thank you. So it's been a pleasure to work with you on a whole bunch of issues, Richard, and thanks for your work in this area. I think one of the opportunities for us is what I've touched on earlier, is sometimes the place that people are more prepared for is using either the pilot project model or research model to be able to demonstrate the effectiveness of policies for which we believe there's evidence. And I get that's frustrating when you think the evidence is already there. Why can't it just be completely widely introduced? But sometimes the pathway between doing nothing versus full scale, let's change the entire policy for the country on this, is we have to figure out the steps along the way. So this is something that is being discussed, and I will be happy to discuss it with you further around the idea of, are there certain places where we can demonstrate that it works safely and in a way that people are going to understand, and then once we do that, be able to spread it from there. And I think that applies to almost everything that we're doing in harm reduction. I'd be open to your views on that, but I'm increasingly seeing that where the federal government doesn't actually hold all the levers, that sometimes our way to be able to demonstrate the effectiveness of a model is to figure out ways that we can institute it in a small scale and build societal support to scale it up from there.
All right. Excellent. Join me in thanking Minister Philpott for her remarks this afternoon. The Minister is going to be meeting just down in the lobby with members of the media who are here, but again, thank you for making this a priority in what I know is a busy day. Good. Now back to regularly scheduled programming. Folks, there's going to be a little bit of commotion as the media moves around. However, I have some directions for you about what happens over the course of the remaining few hours that we have together. We are already at 1:30, and of course we are going to conclude by 4 p.m. today. Here's what happens next. Having spent the morning in 8 groups, we're now going to bring those peer groups together. This will be an opportunity for one side to share with the other the substance of your discussion this morning and the recommendations that you would like to propose. As thoughtful, empathic listeners, the peer group is going to take all of that in, and they're going to offer some succinct, constructive feedback. You're then going to flip, and the other group is going to share its recommendations with the other peer group providing some feedback. The purpose here is to eliminate any duplication, to eliminate any contradictions, and to come out with a good set of, maybe 8, maybe 12 recommendations in each of these 4 areas. So these are going to be larger groups, and, admittedly, everyone's done a lot of talking and a lot of listening at this point, and getting in a larger group will feel perhaps less comfortable because we're tired, right? So be gentle with yourselves, and know that by about 3:15 this afternoon, I'd like to have everyone back here, and I'd like to have 2 representatives of each group ready to present some highlights of your recommendations, your thoughts on the intended outcomes, and those areas where you think more conversation is needed because consensus hasn't yet been found. Is that clear, what I'm asking from you? No. Thumbs up? Thumbs up? All right. Well, the good news is we've got our crack team of facilitators and moderators and scholars who will be in each room, and they know exactly what happens next. What you need to know is the room allocations so you know where you're headed next. We are bringing together A1 and A2. This is supply side drug markets and continental border control. This is headed to room West 101, just back through the double doors there. So both groups will meet together. For interinstitutional collaborations and justice policy and practice, you're going to be just behind me in our well breakout space. For drug regulation and models of decriminalization, you're headed upstairs to the second room along the corridor, the Link training room. And lastly, racialized harms, equity and harm reduction, you're headed to the Link boardroom. So head there now. Our team will meet you, and they'll take you through the next 90 minutes before we see you back here ready to conclude. The Link boardroom is upstairs.
Right here, right?
That's right behind me here with Caitlin. Good. Oh, no. Fair enough.
They laughed.
Good.
They have a training. Okay. I'm just going to ask these others. Sure, yeah. I'm going to try to project, but we don't... Yeah, it's just a bit noisy here. So what we're going to do, the plan here is we're bringing two groups together. And the two groups, the first one was talking about system-wide shifts in justice policy and practice to reduce harms and improve treatment and public safety outcomes. And the other group was looking at interinstitutional collaboration between police and health professionals for first response. Did I get that right? The right people here? So the plan right now is we're going to have one person from each group just read out the 4 recommendations from that group. And then we'll have the other group read out theirs. And then we're going to offer some feedback. And we're also going to see if there's any areas of overlap or things might be combined and make sure there are no contradictions. So I volunteered from our group, and so we're just going to start by talking about the recommendations. We won't right now touch on the outcomes and the areas of disagreement and stuff like that, just to sort of get the topics out there. So